So our next speaker will be Jason Itri from Hospital of the University of Pennsylvania. He's going to talk about using the web-based application to automatically identify discrepancies in preliminary interpretations provided by radiology residents during independent call.
Good afternoon. So today I'm going to be talking about using a web-based application to automatically identify discrepancies in on-call reports.
No, you're good.
Okay. I have no disclosures. Two primary objectives for this talk. One is to describe a method for to identify and track discrepancies in resident and fellow preliminary interpretations on call. And the second objective is to provide examples of how discrepancy data can be used to measure resident and fellow performance, evaluate the impact of educational interventions, and determine the relationship between performance and fatigue. So the background of this project is that it's common practice in many academic hospitals for radiology residents and fellows to provide preliminary interpretations for radiology exams off hours. And while many departments have established peer review systems for evaluating and reporting radiologist performance, there are few equivalent programs for evaluating and tracking radiology resident and fellow performance. The problem is that residents and fellows can interpret thousands of studies every month. And unless there's a system in place to tag a discrepant report in the RIS at the time of dictation, the process of reviewing every on-call report is prohibitively time-consuming. It's a large volume of studies that are read overnight. Manually entering discrepant cases in a database is also time-consuming and doesn't ensure 100% review. And anytime you want to retrospectively review reports for discrepancies, you have the same sort of limitations. It's incredibly time-consuming. So, at our institution, about 2 years ago, the IT department developed a software program called Minerva that pulled all the on-call reports out of the RIS database and populated an Access database. And that allowed the program director to manually review and grade on-call reports as agreement, minor, or major discrepancies. The reason this software program was developed is because every once in a while she'd get a phone call from a faculty member who said, you know, this resident or fellow isn't doing very well, you need to do something about it. And she wanted a more objective way to evaluate that resident and fellow performance. And in this day and age, quality and safety really is a focus, and it's something that, you know, we should all be looking at resident and fellow performance and having some objective, formal way of reviewing their performance. The problem with the system, which worked very well, was that, again, it was incredibly time-consuming. It would be several hours a week just to review a quarter of the reports overnight. There were easily 200 reports every night, and she would go through about 20 or 30 of those reports. And the data was very good, but it wasn't 100% review. So what we did was she had about 2 years' worth of data, 2 years' worth of reports that had been graded as agreement, minor, or major discrepancy. And we tried to develop PHP scripts that looked at the final report, compared it to the prelim report, and tried to identify specific words or phrases that indicated discrepancy. So the first part of the project is we looked at about 1.5 years worth of the 2 years of reports. It's about 65,000 reports that were graded as agreement, minor, major discrepancy. The slide's a little misleading. About 55,000 of those reports were automatically identified as agreement by virtue of the fact that they weren't changed between prelim and final. So really what we were working with was about 10,000 reports, and a majority of those were minor and major discrepancies. The data set was limited to ED studies, and it wasn't 100% review. It was really, you know, the program director focusing on the first weekend of call, the first week of night float, and any resident who had been reported as having problems on call, or fellows. We looked at all of those reports and, you know, calculated a text difference between the prelim and final, and that was one parameter we looked at. Another thing we did was we separated the prelim from the final report, and we looked to identify words and phrases that indicated discrepancies. So first, we really focused on the minor and major discrepancies and looked at what was being said in the faculty-modified final report. So what we found were two different types of phrases that we could use to automatically identify discrepancies. One is a phrase or word that actually indicated discrepancy. So words like disagree, ignore, changes to the preliminary report. And then a second set of phrases that indicated communication of some sort of change in the report. So conveyed to, discussed with, reviewed with. And then the third parameter was the percent of text difference between the prelim and final report. And we found that very reliably, if there was a less than 5% text change, that was an agreement. And only 2 out of the 10,000 plus reports actually violated that rule. So that was a pretty good formula that we used. And then a text change of greater than 30% indicated a higher probability of discrepancy. And that was actually a very valuable part of the formula, because that, you know, greater than 30% text change actually identified 30 or 40% of the discrepancy. So that was a very, very useful part of the formula. So using that year and a half worth of data and looking at the changes, we designed a script that calculated the percent text change. It also separated the faculty modified version from the prelim report, developed a weighted score for the presence of each word or phrase indicating discrepancy. So something like disagree had a very high weighting because that usually meant that there was a disagreement. And then we developed a score for the percent text change, put it together, and made a very simple formula that went through the last year and a half's worth of reports and spit out a number where there was a threshold. If it's below that threshold, it's an agreement. If it's above that threshold, it's a discrepancy. So when we back tested that, it picked up more than 90% of the major discrepancies. It picked up more than 90% of the agreements, and it looked like it was going to work well. We had saved the last 6 months worth of that 2 years worth of data to sort of prospectively test the formula. So when we did that, it was again about 10,000 reports. And what we saw was that it didn't pick up quite as many discrepancies as it had when we used the year and a half of data, but still a little over 80% of the discrepancies. It picked up about 80% of the agreements. The problem with the script is that it incorrectly identified about 436 agreements as discrepancies. So, when you look at the total number of discrepancies, 186, you have 4 times that many studies being identified as discrepancies when in actuality they're agreements. And there are different reasons for that. The initial data set was generated off of ER studies. We did the same algorithm to inpatient studies and saw very similar results. 75 to 85% of the discrepancies were picked up. 87% of agreements were picked up, but again, a huge number of agreements being identified as discrepancies by the code. So, in conclusion, if the goal was to identify discrepancies, it did a pretty good job. The problem is, out of all those reports, you got to spend a lot of time looking at agreements. So it depends on if you want to look at it glass half full, glass half empty. You started with 9,000 reports. When you use the auto discrepancy script, it dropped the total number of disagreements or discrepancies to 1,800, and then of those 1,800, about 500 are discrepancies. So you saved yourself some work. But at the same time, 3/4 of the reports you're looking at are still agreements, and you're still wasting a lot of time. So why did the script end up being so inaccurate? The big part was the variability in faculty addition. So there's either extensive description of clinically unimportant findings, or the faculty member felt it necessary to sort of restate everything that was said by the resident or fellow in a different way, which really had no substantive change. And while the text change picked up a significant number of discrepancies, it also picked up a significant number of agreements and called them discrepancies. So it both worked in our favor and worked against us. Other things that sort of mucked with the formula is when there was a major discrepancy, but the faculty member didn't call anyone to tell them. So that led to disagreements being called agreements. Then there are modality-specific styles of dictation, and then for some reason there was some change in the style of dictation. I think some faculty became more in love with disagree and ignore and started to use that much more frequently. So for example, there'd be an abdominal film where they would disagree that the NG tube was in the fundus and say that it was in the antrum. So that kind of, there's no need to do that sort of thing, but it does kind of mess up the formula. The good news is that all of these things are modifiable, very easily modifiable. When you pull the data from the RIS database, you know who the faculty members are. You can look at where there's a discrepancy between the auto discrepancy code saying agreement or discrepancy and when the data was actually called minor or major discrepancy by the program director, and go back to those faculty members and say, hey, please, you got to cut down on the extra stuff, really just talk about what's relevant. You can go to where there was no notification with a major discrepancy and explain to that faculty member, you need to notify. And really, the 30% text difference, if you spread that across all the modalities, it wasn't actually that good at discriminating between discrepancy and not. But if you broke it down to MSK versus body CT and changed what that threshold was, you actually got much better results. So that would have been phase 3 of the project, but we actually went a different way. And instead of modifying behavior in terms of how much they said and notification, we actually instituted a standard set of macros that when the faculty member initially reviewed the on-call report, they were forced to use one of 3 macros. One macro was an agree, one macro was minor change, one macro was major change. The other change we made was we instituted a standard global notification macro. So all the different ways to notify someone were now shrunken down into one standard macro that everyone was supposed to use. So it became a lot more difficult to test and improve the code when now all the behavior had been modified and we sort of had the data anyways. We based on the fact that faculty were using macros now, we know what's a minor or major discrepancy. But this sort of project is still very good. especially if you want to do any sort of retrospective review. I mean, if you want to look at several years worth of data and you want to shrink 50,000 reports down to 10,000, this will probably do a pretty good job. And we're still looking at other ways to use it. We don't have 100% compliance with using the standard macros. We've got about 80%. So there's 20% of reports we still need to identify, and this is where we're still going to continue developing this sort of code. So why is tracking discrepancies important in the first place? Well, resident and fellow discrepancies and discrepancy rates and performance is really the cornerstone of our quality and safety dashboard for resident and fellow performance. And it's something that has become very popular in our institution in the last couple of years. One of the things we do now is every year we establish performance benchmarks for the different modalities in terms of minor and major discrepancy rates. We look at ED versus inpatient. We look for ways that we can improve. We also calculate minor and major discrepancy rates for all the residents on call for different shift types and look at if any residents are falling outside of 1 or 2 standard deviations in order to get them more specific intervention. Another way we've used the tracking of discrepancies is in the first 8 months, 10% of our major discrepancies were acromioclavicular joint separations, elbow joint effusions in the setting of trauma, and osteochondral fractures of the knee and ankle. So we designed 2 missed case conferences reviewing all of those misses and giving additional education to the residents, and we saw about a 65% decrease in the number of those misses over the subsequent 9 to 11 months. And I'll tell you, in the last 6 months, we haven't had a single one of these misses by the residents. In contrast, if you look at the fellow misses before and after these lectures, there is no change, and that's because they didn't go to the lectures. And the misses that we see now related to these are really fellow misses. So very profound impact of an educational intervention that we can continue to monitor. And since then, we've designed probably 10 or 12 different missed case conferences covering all the major MSK misses from head to toe and plain film, chest, abdomen, pelvis, CT, ultrasound, chest, abdomen, pelvis. And we're still waiting about 6 months to get that data, but so far it looks very good. The third thing you can do is, because you're pulling data from the risks, you have all the information. You know when the study was done, you know who ordered it, who read it, when it was prelimed, when it was finalized. So what we did was we looked at the resident 12-hour shift. This is a night float shift that's over 14 days. They work a 12-hour shift from 7P to 7A. And we broke down the volume of studies that are transcribed during a 2-hour block and the number of major discrepancies during that 2-hour block and plotted it over the 12-hour time course. And what you see is that there's around a 2 to 2.5% major discrepancy rate for the first 8 hours of the shift. It starts to drift up during hours 8 to 10, and then it really pops up during the last 2 hours of the shift. And I didn't show the graph for volume, but the overall volume is actually dropping this whole time. So it's not an increase in volume that's leading this increase in discrepancy rate, it's fatigue. It's the length of a 12-hour shift, day after day, that's really making them tired and they're starting to miss stuff. And if you break out the last half hour, the discrepancy rate's up around 5%. So, we took this data and we compared it to the fellows who work only a 10-hour shift. And you see, one, that they perform much better, which you'd expect. They're board-certified fellows. And two, you start to see the same trend, but then they only work a 10-hour shift. They don't have that big peak at the end because they don't have the extra 2 hours. So we're going to change our call structure starting in July, where the resident night float shift is now only 10 hours, and do that for about 6 months and see how that works out. So in conclusion, discrepancies in resident and fellow preliminary reports can be identified using basic natural language processing algorithms. It really was a couple of weeks of work, and we could have done much better stuff, but we're handicapped by the fact that we already changed the behaviors with the standard macros. The process is dependent on being able to provide feedback to interpreting radiologists about word choice and style, and identifying and tracking resident and fellow discrepancies can provide a wealth of information, really should be part of any quality and safety effort at an academic institution. Thank you.
Do we have any questions from the audience? If so, please come to the microphone. I have a couple questions I'll just start off with. I think this is actually wonderful work. What I really like is the combining this data with tailoring your educational experience, for providing that feedback mechanism and also being able to then understand how it impacts your call schedule and things like that. I think it's wonderful. Now, you mentioned that you moved away from keyword extraction into template adoption, and you were talking about trying to understand, but now you have the ability to test how your compliance on template adoption is because you already have the keyword extraction. And I might have missed a couple of those, that one metric for how you were tracking the template adoption rate. Did that improve reduce your false positives? So the questions are, how did you validate your template adoption?
Okay.
Because now you already have the keyword extraction methodology. and that was able to combine the, you were able to reduce your false positives by looking at the macro implementation?
Well, so we didn't use macros. So the initial study part of it, the first 2 phases had nothing to do with macros.
Okay.
It was all just free text that a faculty member would review the next day,
right,
and they could dictate any way they want. And we tried to say, okay, if we were at an institution where they don't use macros, they can't use macros, if they just edit it, put in what they wanted, could we reliably identify discrepancies? So we had 2 years of reports that were already graded by the program director.
Right.
So we knew a significant number of those were already minor and major discrepancies. We took a year and a half, we looked at what was said and correlated that with minor and major discrepancy, built the formula, back tested it, and it was 90% picking up the discrepancies, 90% picking up the agreements, and about a quarter to a half were agreements incorrectly identified as discrepancies. We saved the last 6 months to sort of because we built the formula off of that year and a half of data. We wanted to forward test it, so we saved 6 months of data. We tested it, and the results actually came out a little bit different. And then what happened was, instead of going back to the faculty members and trying to modify the way that they dictate, shorten the additional stuff, not restating what the resident said, getting notification, we instituted a standard set of macros. So every faculty member who reviews an on-call report now has to start with standard macro agree, minor change, or major change. And there's a specific string of text that now the only PHP script we use is one that finds that text and segregates it into agreement, minor, and major discrepancy. So we've sort of short-circuited the whole loop and just gone right to making the faculty use one of those macros.
Has that changed the percentage of discrepancies from 3 to 4% to a higher ratio or lower ratio?
Yes. So these, what's interesting is these numbers are actually low, and it's because it's only ED studies and it's only a subset, and it combines both residents and fellows. So when you actually, that's one of the things is we have about 80 to 85% compliance now. And I retrospectively went back and looked at 100% of the first 2 weeks of night float for the last 3 years. And the major, we sort of ignore minor discrepancies now because they're really meaningless, and there's so much variability between faculty members that it's actually disheartening for the residents to be called on for minor discrepancies. We focus on majors, and what it looks like is the real major discrepancy rate for residents is probably about 2 to 2.5%. And that will change. We now can look at it by modality. It'll change by rotation. The first 2 weeks of night float's 3%. The second 2 weeks of night float's 1.5%. So all kinds of different things we can look at.
And the last question is, do you have that broken down by resident year? Do you see a dependence on the year?
Yes. And another really interesting part, and I wish I had more slides to show, but we don't only look at the impact of fatigue, we look at the impact of volume. So second-year residents interpret plain films, ultrasound, CTs. Third-year residents interpret plain films, ultrasound, CTs. Between second year and third year, the same class, my class, had a 50% decrease in major discrepancy rate for plain films and ultrasounds, but a 50% increase in CT major discrepancy rate. So we covered 2 different hospitals, inpatient and ER, broke it down, and it was increased across the board. And what it turned out to be is the third years on a different call shift are interpreting 2 to 3 times as many CTs, and that's probably what's leading to the increased discrepancy rate. But other than that, you actually see a pretty good decrease in all the other modalities from from second year, third year, fourth year, and then on to the fellows who have the lowest overall discrepancy rate.
Jason, just a quick comment. You didn't include the exam volume. You said it actually goes down, and maybe Dr. Kopinski, so she might be able to comment on this. But my understanding is that there's an inverse effect, that sort of your vigilance has kind of a funny curve to it. There's an optimum level at which you operate. Too few cases and your vigilance drops, too many and your vigilance drops, and there's kind of an optimum in which you operate. So some of this effect may also be actually that the work has fallen below the level at which you need to maintain your vigilance.
Possibly. I think a lot of those studies were done. So I think there's one fundamental difference between what radiologists do and what every other physician does. I think when we're on call, it's high volume, high workflow the entire night, at least where I am. I mean, from the minute you step in the door, you're reading the same amount of studies. And when you actually look at the volume, there's a little bit of a peak here, but then you're reading the same volume of studies here, as you are here, as you are here, and as you are here. So there may be some effect of vigilance, but in fact, you're reading the same number of studies this whole time. Some people also argue there's a circadian component to it, but when you break this down by day 3, day 5, day 7, day 10, day 14, it's the same exact pattern. So that may be some component of it, but I think there is also a fatigue component to it.
The last question we got via text was, that's great. How did you capture the preliminary report? A lot of RISs overwrite their prelim reports, and now you're showing the poster child for what you can do if you don't if you can avoid that.
Right. So we have GE RIS, and we have a custom table that saves every version of the prelim report. So if a resident changes the prelim report 10 times and then the faculty member goes and overwrites it, I still get any prelim report I want. What we've gone for is the most recent prelim and then compared it to the final. So I think we have the advantage that in our RIS, it saves every single prelim report. It may not display it to the referring physicians if it's overwritten by the faculty, but I still pull it for our system.
Just make a quick comment on that. We have the same risk that you have, and we didn't know for years that it actually did store the prelim report. They just don't expose it for users to get it. So like Marcus was saying before, you have to hack into your RIS and go and get it because it's there. It never deletes anything, and I can't imagine any RIS actually deletes a prelim report. It just may not expose it, and so you have to go and get it and pull it out. And actually, at our institution, we actually grab it, slap it onto the final report, and send it out when the final report goes out, so that the referring docs can't say, "Hey, you pulled the rug out from under our feet."
So actually, our old RIS, IDX Rad 9, did delete the preliminary report. We stole it because we actually send our prelim reports out off to the EMR, so we captured it on the HL7 side and then stored stored that extra copy because we actually exported it out to the EMR. And so that was the only way we were able to get it because our RIS did actually delete the prelim when it got the final.